です。Okay, Carlos, Alex, can you see my slides? It's okay?
Yes.
Okay. So, first of all, I'm so honored to join this wonderful seminar. I appreciate Dr. Carlos and Dix and Asado and everyone's. So today, I'm talking about precutting and hybrid ESD tips and tricks. This is my COI. And these are beautiful images of Kyoto, cherry blossoms, temples, shrines, and a beautiful lady in downtown. So please, please come to Kyoto someday. And yeah, I'm an endoscopist, and I am a runner as well. So I sometimes run overseas with international friends, including Brazilian friends. And first of all, yeah, as you know, there are three main endoscopic resections for colorectal polyps, such as cold snare polypectomy, EMR, and ESD. Regularly, it is decided according to the size of lesions and malignancy or not. So for tumor characteristics, please use this kind of classification using NBI. This is nice classification. It is used in the world as Dr. Sano presented in his previous lecture. And we use genetic classification with magnifying endoscope like this. And if you use this classification, you can predict histopathology like that, and you can decide a therapeutic method for each region. And as you may know, there's another classification from South America, and Dr. Carlos Santos with his colleagues, including me, reported a nice paper for tumor characteristics using laser endoscope. So please use NBI or PLI for tumor characteristics and decide an appropriate way of endoscopic treatments. And EMR or ESD is very, very difficult for some situations, some regions. But in our guideline, Japanese guideline says EMR is performed to regions up to 20 to 30 millimeter for achieving en bloc dissection. Yeah, we Japanese like en bloc fashion because en bloc dissection is very useful for accurate histopathological assessment and a low rate of recurrence. That's why we prefer en bloc dissection. But it is a little bit subjective, so please ask EMR ESD experts in Brazil, for example, Dr. Arantes or Dr. Nelson Miyajiwa and other ESD or EMR experts in Brazil. And as you know, EMR for regions more than 20 millimeter is very challenging. As you can see, the en bloc dissection rate for those regions are less than 50%, very low. And yeah, as you may have an experience about this kind of region. So in this region, unfortunately, much piecemeal and long time EMR was performed like that. So for these kind of regions, ESD is a possible resolution. However, ESD is difficult. This is a paper from United States. The first author is Peter Draganov. He's my friend. He's also an. And they summarized, they analyzed the failure of ESD for various sites of ESD, including 399 corrected ESD cases. And regarding type of ESD, colon is highest risk factor of all sites of gastrointestinal tract. So ESD has some problem. And first problem is, as you can see, ESD is still difficult, especially for colorectal. And the second problem is ESD needs long procedure time. For resolving the procedure time, hybrid ESD was developed. It is a technique for decreasing procedure time of ESD. After full circumferential mucosal incision, like that, the second image of this slide, and followed by submucosal dissection a little bit. And finally, snare resection is performed, and we achieve en-bloc resection with shorter time than regular ESD. And this is a nice paper from Korea to compare ESD with hybrid ESD. They analyzed 78 cases, and these cases are divided into ESD or hybrid ESD. Surprisingly, in ESD group, they failed some cases for planned ESD, and they switched planned ESD to hybrid ESD. So sometimes the hybrid ESD is performed as a rescue of ESD. Please remember that. And this is a result of the study. As you can see, ESD's procedure time is significantly longer than that of hybrid ESD. So it means the procedure time of hybrid ESD is shorter than a regular ESD. But the important thing is timing for snaring. Too big region without dissection is not good for the timing of snaring. So the timing of snaring is like that. Dissection before snaring is performed until less than 5 millimeters of a slit of a snare handle, like that. So please squeeze, close the snare. And if the slit is more than 5 millimeters, please dissect more and snaring again. And this is their limitation, their important thing for hybrid ESD. However, I think hybrid ESD needs some submucosal dissection. It means hybrid ESD is difficult, similar to ESD. So we need another resolution for that. And precutting EMM is my recommendation. It is a technique in which snaring is performed after full or partial circumferential incision of the region with a tip of snare or ESD knife without any dissection. So it means easier than hybrid ESD. And some papers showed its efficacy for en-bloc resection with short procedure time. As you can see, this kind of 30 millimeter lesion is now first mucosal incision is performed, but only incision, no dissection. And then snaring is performed like that. And as you can see, within 20 minutes, this lesion was resected en-bloc. And histopathological results showed low-grade adenoma without any margin. And there are two methods of mucosal incision. Yeah, of course, full incision is good method for achieving en bloc dissection. However, for a smaller region or a region in a good location, partial incision is sometimes enough for achieving good snaring. And for mucosal incision, please use end cut mode. I recommend end cut mode I in Bio 3 in ORV. I'd like to show a movie about precutting EMR with full incision. This is a case of 75-year-old female, and as you can see, there is a lesion. The size of lesion is 25 millimeter, and we diagnosed it as SSL with dysplasia. So first, we do mucosal injection using hyaluronic acid like that, and you can see high elevation is achieved. And with a tip of snare, we incised around the region like that. And this is the anal side. And now full circumferential incision was performed. After that, we added additional injection like that. And then snaring was performed like that. In this case, unique shaped snare was used. However, regular round snare is possible for precutting EMR. And after full circumferential incision, the tumor was shrinked and snaring became so easy. And finally, we achieved en bloc dissection like that. And histology showed SSL with dysplasia without any margin. For precutting EMR and for hybrid ESD, injection solution is very important. Normal saline is not recommended because its elevation disappears easily. So available solution is different in each country. In Japan, we can use hyaluronic acid, and also we can use sodium alginate. And in America, like that. But I heard also in Brazil, there are no hyaluronic acid and there are no polymer or other agent for endoscopic treatment. So I recommend for precutting EMR, please use hyaluronic acid for teardrop. My friend, Dr. Arantes, already published off-label use of this teardrop hyaluronic acid for endoscopic resection, especially ESD. And we previously performed a study about precutting EMR. So I'd like to introduce our study. In our study, it was a retrospective setting. We collected precutting EMR cases. The size of lesion was 10 to 30 millimeter. And it was a multi-center study. The cases collected in three institutions. And totally 167 tumors were collected. And in almost the same period, standard EMR was also performed, and we also collected those cases as a control. And after collecting all cases, we performed propensity score matching, and finally, precutting EMR and standard EMR are compared for lesions less than 20 millimeter and less than lesions more than 20 millimeter. And this is the main result. Lesions more than 20 millimeter. As you can see, envelope dissection rate of precutting EMR was significantly higher than that of standard EMR for regions more than 20 millimeter. And regarding procedure time, precutting EMR's procedure time was a little bit longer than standard EMR. However, it was 19.5 minutes, not so long as ESD. So I think this procedure time is acceptable for endoscopic treatment. And we also analyzed local recurrence after EMR for lesions more than 20 millimeter. And fortunately, precutting EMR as a group showed low recurrence rate like that. I'd like to show another precutting EMR case as a rescue of EMR. So this is a lesion 16 millimeter in size on the cecum. And first we performed BLI magnification like that, and we diagnosed it as adenoma. And we tried EMR. However, as you can see, hematoma happened in several areas. So elevation was not achieved enough. So we tried to precutting EMR. So additional hyaluronic acid was injected. And then we used a tip of snare and mucosal incision was performed like that. And in this case, the location was not so bad. So we performed partial mucosal incision like that. And then snaring was performed after additional injection. So I think precutting EMR can be used as a rescue of EMR when the elevation is not achieved enough, or the tumor's location is not good for doing regular snaring. Unfortunately, in this case, envelope dissection was achieved like that. And precutting EMR is also useful for recurrent lesions like that. So another tips of precutting EMR is there is a special device in Japan for precutting EMR. Soten is the name of this device. It's a special snare with a disc tip for hybrid ESD and precutting EMR. It enables accurate incision and dissection, including hemostasis with this disc tip. I'd like to show a movie about precutting EMR with this Soten. After BLI magnification, we diagnosed it as adenoma. So we did precutting EMR like that. After enough elevation of mucosal injection, we used Soten, and the mucosal incision was performed like that. So it's smoother than tip of snare, and when bleeding happened, bleeding can be stopped with this disc tip. And after full circumferential incision, snaring was performed like that. And fortunately, the lesion was resected en bloc, like that. Previously, we collected 50 cases of precutting EMR with Sorten. Then we analyze the efficacy of Sorten. And this is our one of the results for the paper. As you can see, en-bloc resection rate of experts were not different from those of non-expert. So we concluded even for non-expert, precutting EMR is acceptable, can be performed. However, please see the procedure time. For non-expert, the procedure time is a little bit longer. So please care about this. But I think I recommend please perform precutting EMR as the first step for learning ESD using snare or ESD knife. And after learning precutting EMR, please proceed hybrid ESD. After full circumferential incision, please do a little bit dissection with the tip of snare or ESD knife, or this kind of special snare. And the partial dissection is performed, please do snaring. It's a kind of practice for ESD. And after that, yes, snaring becomes easier than precutting EMR. Like that. And for mastering ESD and precutting EMR, please join hands-on seminar like that. And our JDDW, our JSG society also held a hands-on seminar every year. So please join it. And as you know, ASG in DDW 2022, they performed ESD hands-on seminar or EMR hands-on seminar. So please join this kind of seminar for learning precutting EMR or ESD. And previously, this kind of animal model was used, and it is still used. However, it is a little bit difficult for preparing. So nowadays, instead of this kind of animal model, artificial training model is released. And it's a prototype. And nowadays, artificial model is like that. You can practice EMR and ESD using this model, and you can do it in your hospital or in your office. So it is very convenient. And C master's expert technique is also important for mastering ESD and precutting EMRs. And he's from Taiwan. They are from Russia, from Sri Lanka, China, and Singapore, Bolivia, Peru, Brazil, and Chile, and Australia. So please come to our center anytime for learning ESD and precutting EMR. So this is my take-home message. Today, I will introduce the precutting EMR and hybrid ESD. Please implement these techniques in the future, and good luck. When I learn, I try to increase public awareness for colorectal cancer screening. Thank you for your kind attendance. Thank you, Carlos. And thank you, Rix.
Excellent, Yoshida. Congrats for your brilliant presentation. Bem, vamos à nossa última aula.
Well, now let's go to our last class. That will be by Professor Yutaka Saito, that is the director of the endoscopic division of the National Cancer Center in Tokyo. And he's also a professor at Tokyo Medical University, and he will talk about the guidelines of the Japanese Society for colonoscopy and screening, and follow-up. Now let's see the video. Eu sou
great honor to attend the second PUCLS International Digestive Endoscopy Symposium. Today's my topic is update on W consensus statement on complex polypectomy and long-term outcome of colorectal ESD.